we've got the minister now. Minister Wong, I think, has been leading this fight against COVID from the front. I think he's been squeezing out 36, 48 hours out of a 24-hour day. I don't know how you do that, Vaughan, but really a warm welcome to you. And may I first of all invite you to address our gathering and tell us a little bit more about what's happening with your work and with the vaccine.
Thank you, Keshav, and thank you to everyone who's given us some time tonight. I recognise a number of faces and other people I'm seeing for the first time. And this is really an opportunity to hear from you, to see how we can help each other to persuade more people to take up the help that is on offer. And it's important for us to understand what's circulating in terms of information and disinformation in our community so we can address it. To have this odd mirror image of the fact that people that look like us are more likely to suffer harm from COVID and at the same time least likely to take up the protection that the vaccines offer. And we've seen a huge amount of harm caused throughout the first and the unfinished second wave in this pandemic. And we know that harm isn't evenly spread. So there's a range of healthcare risk factors, a range of ethnic origin factors, and indeed, bluntly, everything that overlays in terms of healthcare and economic inequalities and where the most harm has been caused. So for me, it's an opportunity to listen as much as anything else, to hear what people have to say, and then to try to agree what we're going to do in the future to help persuade more people to take up the offer of help, support, and protection that's available. In terms of my work, well, lots of it is about listening to people, because you always get advice as a minister, but ultimately you still have to make choices. So we get advice on what to do, we get advice on the public health situation, but that still leads to a choice that is then made. And I know that when we look back, we'll look back and we'll say there are things where we recognise we might have made mistakes, and other times where we think that our knowledge has definitely developed as it has, and we think we could have made better choices with better knowledge. I think that reflection is really important, because if we try to persuade ourselves we've been perfect at every opportunity, then we'll never learn. And I think that an element of humility is important in terms of our engagement with the public. Otherwise, they won't trust us, and why should they? And that, I think, comes back to, I think, one of the key challenges for us, and that's trust. To get people to trust us and to maintain that trust in the choices we make about restrictions, but also the information that we're broadly discussing tonight about the vaccine and its safety. That's why I think it is really good we got the MHRA here with us, because the vaccines aren't made available because I decide so. They're only available for lawful use because an independent regulator says that they're safe and effective. We then get advice on how best to do so, and Richard Roberts takes part in those JCVI conversations on the advice, but then I then have to make choices to implement those. And obviously Jill and her team are leading that on a national level, and collectively she'll be able to tell you lots about what that then means locally as well. So thank you everyone for your time, not just tonight, but everything that everyone is doing to help protect people right across our country. I'll stop there, Keshav, because as a politician, I could talk all night without a script. I look forward to hearing from others and answering questions that come my way. Thank you.
Very good. Thank you, Minister. That's very welcome. So how long can you stay for? That's the question. So that is how we'll then direct questions to you.
I have about an hour, so I can stay here till just after 7 o'clock.
Perfect. So what I'd like to do then is we'll wait for the answers to questions to come over in the sidebar before we bring you in to answer them. Is that okay?
Yes, no problem.
Thank you. So we have already a list of questions based on various feedbacks we've had from the communities. And I'd like to kick off with June Rain as the ultimate approver of these vaccines that are in use in UK. June. A lot of young women have a big concern about the vaccine having effect on their fertility. Now, I believe you would have checked all these data before you approved it. So what's your take on that?
Well, thank you, Professor Singhal. Good evening, everybody. And may I first say how delighted I am to be here this evening and to participate in this well-organised event, bringing so many people together. And as the Minister has just said, to listen, because I really want to hear and think about and reflect with you on the issues that are at the front of your mind. As you say, Professor Singhal, a key question for many young women in their fertile years, their childbearing years, is, will this affect my fertility? And the answer is a very clear and a very reassuring no. As the independent regulator, we expect to see very well conducted and thorough studies looking into the effects on what we call reproduction. And it's looked at extraordinarily carefully, not just by our expert assessors whose daily life it is looking at this kind of data, but also by our independent expert working group chaired by Professor Sir Munir Mohammed. And so there's a double layer of independent expertise. When we say no effects on fertility, that has been checked and checked again. So I hope that is a reassuring response.
Many thanks. On that issue, with a slightly related one, do you think it's got any effect on the people who are already pregnant, or people who have just given birth and on breastfeeding?
Well, thank you again to carry the story further. As many people will understand that in regulation, we do not require studies in pregnancy for very good reasons, that pregnant women are a rather special population and we don't routinely ask for them to be included. But we do look for data, and both women who become pregnant during the clinical trials and also the close follow-up of women who become pregnant. And what we can say, in addition to the reproduction studies, is that we believe there is no evidence at the moment of harm in pregnancy. But we do have what you might call a gap in our knowledge. We're working hard to fill that gap. And so the advice in the meantime is one based on an individual discussion that a woman will have with her healthcare provider about the risks she may see in the job that she has or the life that she's leading. And so a woman will make a choice, a risk-based choice, on the benefits and the risks. And that applies both to when you're pregnant and when you're breastfeeding. So it might sound a little complicated. It is definitely a yes, you can, but bearing in mind there is still a level of uncertainty in the knowledge that we have that we're working hard to fill. And I may want to add, we're all also in touch with the Royal College of Obstetricians, Gynecologists, and the Royal College of Midwives about how we will fill that knowledge gap.
Perfect. Thank you. I think you made it very clear that there's no effect on fertility. And as far as we know, there's no adverse effect on pregnancy or breastfeeding, though there's a gap in our knowledge. On a slightly related issue, Dr. Richard Roberts, if I can come to you, there is a big controversy going on that the vaccine contains pieces or parts of aborted fetus, or it's been developed from aborted fetus, and that is a big no-no to a number of our populations. What is your thought on that?
Thank you, Professor. The viruses which are necessary in the Oxford AstraZeneca vaccine have to be sustained in a laboratory in cell culture. And the best kind of cell culture for viruses that you're going to use in humans are human cells. And this is a common practice in laboratories around the world and has been for many decades. A number of the cell lines that are used to sustain these viruses and to propagate them did originate from fetal tissue from aborted fetuses collected in the 1960s and 70s. So there is no fetal tissue in the vaccines at all, but the cell lines originated some 40 or 50 years ago from tissue that was collected from legally aborted fetuses. So these would have been aborted for medical reasons, and then cells collected, and those cells are ideal for preserving and propagating these viruses, which we depend on for a number of different vaccines and other medical purposes. So that's the origin of the cell line. These cell lines are then propagated in laboratories over decades, And when the viruses that carry the information necessary to instruct your cells to make the protein to help you to become immune to the SARS-CoV-2 virus, those cells are purified away from any products that were used to culture them, and so there is no cell product left in the vaccine which is then used. But it is true that the processes used to propagate those viruses for the vaccines, in common with many other vaccines that we have and many other medical uses, were originally harvested from tissues from aborted fetuses.
Thank you. But you made it very clear that there is no fetal tissue in the vaccine. I think that's
yes.
the message, yes?
Yes, that's correct. So the products are purified, so there is none of this cell culture tissue. So by the time that it's been through generations and decades of cell culture in the laboratory, there's no fetal tissue left. But the cells that are originally derived are completely purified away. So there's no cell products left in the vaccine itself. It's only the virus which is used in the vaccine.
Thank you. Dr. Gillian Richardson, we've got a very large audience today of BAME communities. You know, and we all know they have been affected disproportionately by the virus, and we know that they are at a high risk. Yet, neither PHE nor PHW have made them a priority or priority target audience for vaccine rollout. Why is that so?
Okay, well, it's really something that is to do with the whole way that prioritization has taken place for the vaccine. So we have signed up in keeping with all the other UK nations to follow the advice of the Joint Committee on Vaccination and Immunisation. And we have our own representatives, so Dr. Roberts and also a senior nurse, Anne McGowan, sit on that for Wales. And the JCVI looked at the mortality risk, the risk of serious disease and hospitalisation that was experienced during the first wave of the pandemic. And based on that information, they looked at the main risk factors for that and concluded that it was age related largely, but also related to clinical conditions. In doing so, they did look at lots of other evidence to do with, could it have been explained by ethnicity? Could it have been explained by another factor? And they drew up the list. And as we know, we've widely publicised that list of cohort groups 1 to 9, with the rest of the population being 10. And the aim is for all adults in the UK to be immunised by the autumn. And autumn is a little bit of a movable feast because it will depend on supply, obviously. But the commitment is there to do so. And similarly, you know, in Wales, a commitment to do so. Cohorts 1 to 4 account for 80% of the avoidable deaths in the first wave. And cohorts 1 to 9 account for 99% of the deaths. So in Wales, we looked and checked on our local data, and we can back up also that when we looked actually at groups 1 to 3, that included 88% of the avoidable mortality. Having said that, JCVI are constantly looking at new research and feeding in new data to see whether, in fact, their position needs to change, whether they need to prioritise certain groups. Certainly in Wales, we're very keen that workplace, for instance, immunisations of the health and social care workforce used, oh, sorry, the light has just gone off in here. I'm on my own in the office, so it'll go on in a minute, that's it. They very much used a workplace assessment tool that has been devised, thank you, by the group that has been chaired, and Heather Payne has been involved with, and that workplace assessment tool has been used throughout Wales. So they use their own risk assessment assessment methods as well to ensure that people were included. But it is definitely a live issue. It's definitely an issue that's still on the table, and it's an issue which JCVI will be working on until this is finished, I think.
Thank you, Gillian. On that, just a side question from me, that as you rightly said, we've got our own workplace risk assessment tool, which has been used extensively in the public sectors in Wales. And it has identified roughly 10,000 people in the high risk category. And I think our group is actually very keen that because these people are continuing to work on the front line and are identified as high risk, that they ought to have some priority and in order to continue our public services. So perhaps that is something you might take back to JCVI and see if we actually get any traction on that.
Yes, definitely. I think that's really worth pointing out. Hopefully those that are in at-risk groups with certain conditions will already be picked up, and you know, that will be advantageous, but I think not all of them are going to be picked up that way. So yes, we will definitely take that forward into our discussions.
Thank you. Minister, I've got a question for you from the sidebar. One of our doctors has asked, are you going to bring in stricter measures for international travel, particularly from countries like India, from where a lot of our healthcare workers are?
I've just come from the Senedd, where we've just moved and agreed the latest set of international travel restrictions. So this is about the requirement to isolate from red list countries, but we're also going to introduce requirements that you may have seen in today's reporting around travel from any part of the world, not just those red list countries, which will require people to go into managed quarantine. At the moment, international travel isn't possible from Wales unless you have your own private plane or boat. So international travel, because Cardiff Airport isn't open, you're going to have to go to an airport in England. You know, if Cardiff Airport, though, is up and operational again, then that would change. When I visited India, I flew home from Chennai through Qatar Airways, and so had a stop off in the Middle East and coming home. Now, that route isn't operating at present, but in the future, this will become more of an issue for our arrangements here in Wales. If you need to go to India and you're taking a plane from any of the English airports that operate, then you're going to come back and you're going to need to arrange for quarantine, and you're going to have to pay for tests as well. So the onus is on the individual traveller to pay for those tests and to make, and those arrangements will be made for you in terms of managed quarantine. Now, the Welsh Government view is, this is underpinned by the advice we've had from our scientific advisor and technical advisory group, and it's supported by a chief medical officer, is that it would be preferable if we had a broader approach to international travel, not just a red list, because we do know that a range of the new variants of concern have come in from countries that don't have a specific travel history with South Africa, for the sake of argument, and they aren't on the current red list. We know that the virus will mutate. It's not a surprise to us. It was always within our contemplation from early on. Just as with the flu virus, there's a change in the flu vaccine every year. So we know that that virus mutates, this one mutates. We're only, though, interested in those variants of concern. So, you know, we think a broader approach to this would be preferable, whilst we make sure that we're in place to track, understand those variants in this country and provide an answer. So, yes, if you're traveling to India, then you're going to have to pay for tests on your return. And it's entirely possible those quarantine ranges may go out and be even broader in terms of wider travel as well.
Thank you, Minister. And another one there about vaccination of children. Has the Welsh Government got any views on the vaccination for children under 16 and the possible effect on the opening or closure of our schools?
Well, June may want to come in on this as well, because there's a point about how the vaccines are licensed and who they're licensed for. So we're currently looking to vaccinate the adult population. And so, you know, there isn't a particular program for wide scale children to be vaccinated. That isn't how they've been agreed. What I think, though, this is part of our challenge in getting schools open for face-to-face learning. Because, of course, some of you on the call being frontline workers, those of you that are, you may have children in one of the hubs already. So there are about 10% of children are already attending school in one of the hubs that we've set up. We're looking to have face-to-face learning for the whole foundation phase, that's children up to year 2 in primary schools, from after half term, so from the 22nd of February onwards. And that's difficult because we need to win a battle of hearts and minds, not just public health evidence for our education staff, but also for parents and carers to send their children in. I think most parents would be looking forward to their young children going back, but there are those that are still anxious and concerned. I actually think that the vaccination program isn't the biggest thing to get face-to-face learning returned. It's actually our collective ability to behave in the difficult way we're all having to live, in managing and reducing our contacts with other people to keep transmission rates going in the right direction. And the vaccination program will continue to protect our most vulnerable citizens from harm. So I think that it's important, I think, to see them in as slightly different questions, but it still requires us all to do things that still aren't normal, are they? You know, this might be the new normal, but many of us still hark back to where we were a year ago, and we didn't have to think about behaving in this way. But this will be with us for months to come. But June, if you want to come in about the point about the licensing and the age range in which the vaccines are licensed for.
Well, thank you, Minister. Yes. They are for adults over 18 in the case of the Pfizer, and I think it's 16 for AstraZeneca. It might be the other way around, but there's for adults. However, as colleagues from the JCVI will know, that there are some particularly vulnerable children for whom there might be a favourable benefit risk, and there are allowances for this in the JCVI guidance, but this would not be relevant to the question about opening schools. In the future, there may be trials, but as we know, children are not the ones who suffer from the risks and the complications of COVID. So you're absolutely right, it's for the adult population.
Thank you, June. And on that, I've got a question for you in the sidebar. That there's been a report in Daily Mail online today that 36 patients who've had this vaccine have developed thrombocytopenia. Is this something you've been made aware of through any yellow cards, or is it just our typical tabloid reporting?
Jill may want to come back on this as well into the Where and Wales, because we do have reports that come back on impacts and reactions to the vaccine, and they're carried out in each of the UK countries as well. I don't know if Jill or June want to deal with this in terms of the slightly differing perspectives.
I think if June wants to answer on that specific, because it's around the yellow cards, we've not had any reports of thrombocytopenia here. We have our system in Wales captures the vaccination programme daily, and if anybody has any reactions, those are entered onto the Wales immunisation system. So we can track every day who has had a local reaction or an anaphylaxis and everything in between. And then yellow cards are filled out by our practitioners. Our clinicians will send them in then to June. So perhaps if I hand over to you.
Well, thank you, Jill. And I'd also like to pay tribute to the Welsh Yellow Card Centre in Cardiff that does a grand job and in fact encourages reporting with champions who encourage health professionals to send us their observations and of course reach out to members of the public too. As of this evening, I'm not aware of a signal of thrombocytopenia, but I'll certainly be checking on our database. It's looked at every day, and we will be publishing, as we announced last Friday, every Thursday, the latest set of data. And that's part of our commitment to sharing everything we know. But the purpose, of course, is to look to see if there's a greater incidence, more reports of something than we would expect by chance alone. And so many people, thankfully, are now receiving the vaccine that we would expect to pick up issues that are naturally occurring illnesses. So the short answer, not aware of a signal, but it's something we will follow up very carefully. Thank you.
Thank you, Jill. I'd like now to turn to some specific cultural issues. And I'd like to bring Dr. Ramzan in here. Dr. Ramzan, you're working with Muslim Doctors Cymru, and you've been very active in the last few days on the social media. The Muslim community is particularly worried about the vaccine containing pork or alcohol. Now, would you like to please reassure our audience on these two issues?
Yeah, thank you for that question, Professor Keshwal. So with regards to the pork side, well, what we can say with confidence is that any of the vaccines that we've authorized in this country, so it's the Oxford AstraZeneca, the Pfizer, and also the Moderna vaccine contains no animal products, let alone pork products. Not only the Muslim community, not only the Muslim councils and people like British Medical Islamic Association, but also the Hindu Council, the Jewish Council, and many other faith group leaders have come out and said that there's no animal products, and in terms of their cultural or religious beliefs, then there's no issues for having the vaccine itself. In terms of alcohol, there is chemical alcohol in the Oxford vaccine, but what our community needs to realize is that this is not the same as alcohol that you consume or drink, and it's such a small amount that the British Board of Scholars and Imams have released fatwas and religious rulings regarding the fact that we can have this vaccine, and it's not what we say haram or impermissible. So that's really, really important to highlight that point, because some people read the vaccine ingredients and don't actually understand that, when they say alcohol, what that actually means. And it's only in the Oxford one, and it's a very small amount. And like I said, we have had fatwas saying that it is permissible for us to have the vaccine. I hope that answers the question.
So you are saying unequivocally that this vaccine or these two vaccines are religiously endorsed. They are absolutely fine for anybody, particularly in the Muslim community, to have without any issues.
Yes, like I said, that has come from scholars from various different sects, and I can put up the BBSI document in the chat box later. But yes, unequivocally, they've said that it is permissible. Obviously, there may be some scholars who take a different route on that, but the vast majority have said that it is permissible based on that. But I want to reassure again, there are no animal products in any of the vaccine, let alone pork.
That's very reassuring. Dr. Noham, I'm afraid you are in the hotspot now. The question is, how are the vaccines being rolled out in Wales? And why have you taken the approach that you have taken for the vaccine rollout, which appears to be slightly different from that in England?
Well, good evening, everyone. So I think the rollout in Wales has not been without its challenges, but in reality, it's been very positive. So far, we have done more than 635,000 doses in Wales. Yesterday alone, we had more than 21,000 in a single day. I think the fact we're using a mixed model is very positive. So primary care practices, GPs are doing an incredible amount of work, and Dr. Ramzan's just talked about his experiences. So the GPs are doing an incredible amount of work. That's part of our model. But we're also using peripatetic teams that are going into care homes to vaccinate care homes, and we've successfully, at the end of January, we had gone through all of the care homes, and the only individuals who may not have received were individuals who weren't eligible. And we're also using a number of district general hospital sites, as well as selected mass vaccination centers or community vaccination centers. So we're using a mixed model in Wales. And I think what we've learned from that mixed model is that it's given solid resilience to our system. So we're not putting all our eggs in one basket, if you like. So that use of general practice, mass vaccination centers, or what we call community vaccination centers, and district general hospital sites, as well as mobile teams, I think that's given us a lot of resilience in the system. As Jill had said earlier, our focus has been on the first 4 priority groups, And we are absolutely on track across Wales to hit the top 4 priority groups by the middle of February, which has been the milestone. And that's gone on very well. So I do think the progress we have made justifies the sort of mixed model that we have taken. And definitely our experience on the front lines is that that's absolutely gone down well with all of our partners locally and regionally.
Thank you. And I think we can take pride in Wales in saying that the number of vaccinations per 100,000 of our population across the 4 nations has probably been highest in Wales. So clearly, I think the approach that you and your colleagues have taken is working. But now, can I also ask you which vaccines are being used in Wales? And are we just going with Pfizer, or are we running out of stock with that? And when are we switching on to Oxford?
So the 2 vaccines that have been approved, the Oxford BioNTech vaccine, as well as the Oxford AstraZeneca vaccines. Those are the 2 vaccines that we are deploying across Wales. And there will be slight variations from place to place in Wales. So for example, if I focus for a moment on the Cwmtaf Morgannwg region where I work. So we're consciously using all of our Oxford AstraZeneca vaccines at this point via primary care. So we're very confident GPs are very confident in delivering vaccination programs, and we wanted to deploy that as quickly as possible. So most of our Oxford vaccination is done via primary care. We're using our Pfizer vaccines through our community vaccination centers, vaccination of care homes, as well as the vaccination in district general hospitals. There might be slight variations from place to place across Wales, but like I said earlier, that mixed model across Wales is absolutely using those 2 vaccines at this point. And like I said, that's working exactly as we had hoped.
Thank you, Dr. Noam. I have a question for June. So there are some studies going on about mix and match. First dose Pfizer, second dose Oxford. Is this something MHRA are considering going forward? And how far ahead is that decision, if at all?
Yes, indeed. There are studies now ongoing looking at the heterologous or one brand and then the second to see if that gives a better immunity, and particularly in relation as we're concerned and thinking about the variants. We would be more than glad to look at that data, but we'll look at it with the same scientific rigor and the expectations that it will be thoroughly assessed also by our expert group before we'd give a verdict on that. But it's a very interesting development, and I'd like to say a big thank you to people who are volunteering to be part of those trials. Really important.
For our audience, I think it's very important to understand that the MHRA, represented by June here, is completely independent body. It is not under government pressure. It decides everything purely on scientific basis, completely impartially. And I think we can be reassured that if MHRA has taken a particular decision, you can be reassured that it has been taken after rigorous scrutiny in your best interests, and not because the Prime Minister or any other minister has said so. Minister, if I may come in here for you, we are here to dispel a lot of myths for our BAME communities, yet skepticism remains very high. And in fact, in East London, apparently, the vaccine centers are being closed earlier because there are no takers. And 40% of some particular communities have actually refused to have the vaccine. In Wales, if we end up with this situation where despite all our myth busting and persuasion, we still have issues, and we know that no man is safe unless your neighbor is safe, would you consider making the vaccine mandatory?
Okay, so on mandating the vaccine, no, we'd have to change the law to do that. You'd need to change the law, and you need to do that in primary legislation. So I couldn't introduce, so we talked earlier about international quarantine arrangements. Those are regulations made into law because I sign off the regulations as a minister. They have to be voted on by the Senate within 21 days, but it's law from the moment I sign them in. You couldn't do that in terms of mandating and legally requiring people to take the vaccine. You'd have to go through the whole Senate and get primary legislation passed. And I understand why some people think that on a surface level that's attractive, but I actually think there's a lot of harm that'll get done if you legally force people to take a vaccine. Every year we talk a bit about mandation and the flu virus and the flu vaccine. And there was a bit of an issue some months ago, and I got asked a question about this in an interview. And that's because when we talk about that, we're not talking about changing the law. We're actually talking about, are we in effect going to require health and social care workers to take the vaccine? Is that going to be a condition of employment? And every year, when we consider it, every year we don't make it a requirement. Because again, you've got to expect people to talk about their own personal circumstances of why they would or wouldn't want to have it. And actually this is about persuasion and getting people to do the right thing for people they care for. And if you're forcing them into doing that, I actually think you lose an awful lot in terms of your workforce. And not only that though, but we know in health and social care, we're not necessarily in a buyer's market. When you think about the people who I think there's much greater understanding of, people who work in social care, on not great wages all the time, if we are then forcing those people to undergo treatment they're not sure of, then I think you'll find less people wanting and willing to go to work in that environment. That will cause real harm to people who need that care. So I think it's an understandable sort of demand in some ways from some people, but I don't think it's the right answer. I still think this is about persuading and explaining, providing people with trusted information about why the vaccines work, why it's in their interests, for their family and their community to do this, and not in my interest as the minister. And I think in Wales, we're going to be able to provide over, hopefully, the not too distant future, some work that Public Health Wales are doing, some indication on take-up rates here in Wales as well. We'll never get that 100% perfect because we don't have an exact record on ethnic origin and data in our records. But I think it will show that we have got an appreciable, a material gap. And if you like, the normal white resident population compared to the Black and Asian origin resident population here in Wales. And I think that'll be important to reiterate that there is an issue for us to resolve. But I'm optimistic that I think that this is the right way to improve take-up and not changing the law, because I think that would make things worse, not better in reality.
Thank you, Minister. We've now got 15 minutes left and I'd like to go into a rapid fire round. Okay, so we need to cover a lot of grounds and very sharp, succinct answers, please. Starting with Dr. Roberts. We've got these variants coming in. Is there any point in having the vaccine if you have a new variant tomorrow?
Yes, because the vaccines are very effective against the variants that we currently have in the UK, especially against the severe end of the disease. And the manufacturers of the current vaccines say that they are able to modify their vaccines for variants that may come along in the future and become common in the UK. Thank
you, Dr. Roberts. Gillian, there are concerns that sometimes vaccines have been given to people who are not in the priority group. And this has understandably shaken a little bit of confidence amongst the audience. What do you say about that?
I think you're right that, there has to be consistency. And so we're very careful that when we talk to all the health boards and the trusts in NHS Wales that come to the Vaccine Deployment Board, that we give them as clear parameters as possible. So with the JCVI, they help a great deal, and they have given more detail below some of the categories. And so we try to use our experts such as Richard and Anne and others to inform us on the rationale behind some of those decisions. And for instance, why children aren't, also included. We also try to help work with the sectors such as, say, social care, to look at social care definitions of social care workers and who is frontline, for instance, and the same with health. I think there's always the issue that at the end of the day, if a centre has 2 or 3 doses left over in a vial, we would rather that those doses go to somebody than be thrown away. So if they can find people in the priority groups, and they do have reserve lists and short notice lists, then we would much prefer that they include somebody in that category. So for at the moment it's 1 to 4. We're now extending into early 5. But we actually always say to them that we would rather that dose was used than thrown. So it could well be that just on occasions, if there aren't anybody, in terms of frontline, if there isn't anybody in that priority group, that they may use those vaccines, but we're talking a tiny amount. And the other thing to say is that we should never judge who we think looks healthy, because it could well be that they've been shielding, that there may well be factors that we do not know about their health.
Thank you. The important thing is no wastage. We don't want to waste the vaccine. And Dr. Ramzan, from a cultural perspective, impotence and infertility are two big things that in the BAME community is exercising people a lot. From a cultural and religious perspective, do you think that there's any justification?
About what? Sorry, I missed that.
About the vaccine causing impotence or infertility.
Sure. Okay. June Rain actually answered this question really well, but what I would say is that there is no evidence to suggest that COVID-19 vaccine causes infertility or impotence. We have been vaccinating for decades. We understand sort of vaccinations and how immunology works. We've never seen any strong evidence of this in any previous vaccination, so there should be no reason for why we should see it in this vaccination either. So there is no evidence or any association with this, and we should reassure our community that these are myths and that these should not be the reason for why we should not be taking the vaccine.
Thank you very much. Dr. Roberts, long and short-term side effects of the vaccine, any significant ones that you'd like to highlight to our audience?
Or short-term effects, these vaccines do make your arm very sore. As you'd expect, a sore arm for a couple of days. With the first dose, a small proportion of people get fever, they feel very tired, they may be off their food for a few days. It seems more common after the second dose. In terms of long-term effects, we've heard about the surveillance that's ongoing with these vaccines. Obviously, we have the trials that have been ongoing for a number of months, but now we have experience of millions of doses in the UK and around the world. So the studies for long-term effects will be active and ongoing, looking for any conditions that may be associated with the vaccines, and those will be kept under scrutiny by the MHRA and reported publicly in their public reports on vaccine safety.
Thank you. And Dr. Noham, the UK decision to delay the second dose by 12 weeks was heavily criticized initially, but today or yesterday, the WHO special envoy came out and vindicated this stand. Do you think this was the correct thing to do, or do you still have any issues about the vaccine second dose being 12 weeks delayed or maybe given at 4 weeks? What is your thought?
We were always clear that the basis for that decision was the right one. And we were very mindful of the concerns that a lot of our healthcare staff particularly expressed around that decision. And we did our very best to reassure on the basis of what we knew. So I thought it was the right decision from the outset. I think it was the right public health decision to get as much coverage as quickly as possible for the rest of the population. I always felt it was the right one, and perhaps vindicated by more recent data that has been published. So I do hope people are now increasingly or more reassured by the more recent data that has come out. But I do feel that we were always clear that it was the right decision from the outset.
Thank you. But June, coming back to you on that issue, the vaccines were, I presume, approved based on the trial data, and the trial data was based on 2 shots at 4 weeks interval. So MHRA must have been in a bit of a quandary at that time about this decision of delaying for 12 weeks.
As Dr. Noam has said, for the AZ vaccine, we have very good data for 12 weeks. Clearly, we looked very carefully at the Pfizer-BioNTech data, where the longest gap was 42 days. But we added into that the immunology data, plus a very well understood biological principle that the longer you leave the booster, the better response that you get. And so I'm there with Dr. Kelechi that leaving it longer gives a better boost, as well as allowing more people the chance of their first effective dose, and a really good decision that's compatible with the regulatory decision too.
Thank you. I think that's again a UK decision that really stands out for its pragmatism and foresight, and I think that's turned out to be a very good decision. Minister, the BAME communities have a lot of resistance, which hopefully we'll be able to reassure today. But how, I mean, you know, you are part of the community there. How would you, as a minister, try and, as a minister in your ministerial policies and in your ministerial work, try and push this forward and ensure that the BAME communities actually take more and more vaccines? You're muted, Minister.
My son was trying to talk to me earlier on, so I thought I'd turn the sound off. I think there are a number of things for us to do. So I think the engagement we're having tonight can't be just a one-off and say, there, well, we've engaged with the communities. It's got to be more than one way to have a conversation. We've deliberately thought about that, not just in the specialist communication support, but in the regular way that not just at ministerial level, but throughout our service we engage, as both at general practitioner level, but also at health board and wider. So every health board has been specifically asked and funded to have some outreach engagement work across its health board area, but it's more than that too, of course. So it is both about the request I've already made at Vaccine Programme Board to look at the data, to get to a position where we can publish that data, and that openness will help us to understand the scale and the nature of the differential. And that is then, I think, about, from my point of view, maintaining an interest. And so I will continue to be interested in what is happening and how successful the various approaches we'll want to undertake are. But it's one thing to say, well, we have a problem, and it's then, well, you then need to know what you're going to do about it, and then to understand if it's being successful or not. And it's also the people involved tonight about telling us how safe you feel it is on the ground. Because if we wander off thinking tonight was wonderful, and everybody else goes away thinking actually that didn't really do what we need it to do, or you find out the message in another week or two hasn't reached everyone that we'd want it to, then we need to know about that. And it's the constant struggle as well with all of the fake news, the anti-vax information as well. The amount of disinformation that is now available and widely shared is frightening. And, you know, as a minister, I can't monitor every WhatsApp conversation or every Facebook post. It's probably dangerous if I could do, actually. So there are much wider questions if I could do that, but that's part of our challenge. I think the final thing that I'd say is that there are times where each of us need to do things because of how we're seen. So, you know, I am seen by some people as a politician who is black, and other times a black politician. And there are times I need to be both. I've regularly said that. So when I go to have my vaccine, I think it's important that I say that I've had the vaccine, and I then make sure that that's publicly available too. So I'm used to every flu season having someone take a picture of me being stabbed in the arm because I'm in groups. I have the NHS flu jab because I've got an underlying kidney condition. I was ill when I was younger. I'm in remission with nephrotic syndrome. It's all a matter of public record. And so that chronic kidney condition gets me an NHS flu jab. So when I have my jab, I'll be making sure there's someone with a camera and it can be posted and make clear everyone should get their jab. If you look like me, this is important. Please take up the opportunity to get your protection when the NHS offers it.
Thank you, Minister. And a final question for you, because I know your 1 hour is nearly up. What is the issue of people who are either asylum seekers or of no fixed abode or do not have an NHS number or for some or the other reason do not have proper documentation? Would they still be able to get the vaccine?
We're looking to vaccinate everyone possible. So we're not going to turn people away. We've had this in a number of fronts. So people who don't have a permanent address, we're working with particular services to engage with them to make sure they get vaccinated. We know that people who are homeless or live in the street and don't have a fixed abode often have a much greater number or more likely to have underlying healthcare conditions that make them even more vulnerable. So that's been a real worry at various points. We're worried about some of the people managed to get off the street during the pandemic, that if we had outbreaks in the accommodation we'd arranged them, that could actually cause a lot of harm very quickly. We've also had this a bit in some of the cross-border issues, trying to work through, if you have a Welsh GP but live in England, will you be vaccinated in Wales or England? And we're saying we'll vaccinate everybody we can, and we'll make sure information is exchanged to make sure that the relevant person in the healthcare system knows that's happened. So it's about working through those challenges to make sure we do get population coverage rather than trying to ignore the fact that they exist or to pretend that actually they aren't people we have a shared responsibility for, because we absolutely do.
Many thanks, Minister. Just the last few minutes, so I'll take a quick question from each of the panelists. Dr. Ramzan, with you being working on the front line, where is the second dose being administered? Would it be at the same location as the first or a different location?
At the moment, from what I understand, is we'll be giving it in the same location. So if we've vaccinated someone in our general practice, then we would be giving the second dose again in our surgery, because we're giving the AstraZeneca. And at this moment in time, my understanding is that we're not mixing, but even though I know that the trials are being taken place regarding mixed dosing.
Thank you, Qasim. Gillian, oh gosh, I've had a brainstorm. Yes, so the issue is about BAME communities, and there's a suggestion that various temples and mosques and synagogues and churches have offered their premises, and that we have a rolling mobile van or something going there a day a week or something. Is this something that you would be looking at?
Yes, thank you so much for asking. We've just been overwhelmed with the many offers of support and help with the venues. All of them have been conveyed to the health boards, and I know that several are actively considering. What they'll be looking for is probably to use those venues for the Oxford AstraZeneca vaccine. The Pfizer vaccine, as you know, requires quite a lot of attention and pharmacy involvement. It's not impossible, though, and it is being used in community venues. But there are some strict sort of guidelines that we need. But the Oxford AstraZeneca, which is a much more stable vaccine, would be much more eminently able to be transported and to be used in such venues. And we do see it as important because we want people to know that we're standing in solidarity with the faith groups that are represented by that venue. So we are open to all offers, and the health boards are actively considering. And even if it is used as a pop-up or if it's used, you know, very much as a publicity opportunity so that people can take pictures and enable people to just feel that they would be able to be at home, you know, this vaccine is for them and is for everybody.
Thank you, Gillian. I think in the audience today, we've probably got representatives from probably every faith group. And I think they'll be very reassured, and I'm sure they'll be out there offering to help you. Dr. Roberts, are the vaccines safe for people suffering from autoimmune disease or immune deficiency diseases, cancer, or other chronic comorbidities?
Yes, they are. These are not live vaccines, so those are the vaccines that would normally be of concern in those groups. So they're very safe to give to those groups, and also highly recommended. Those groups are particularly susceptible to severe outcomes. And although we don't have trials to show yet that the vaccine is highly effective in those immunocompromised groups, the fact that the vaccines all work extremely well in older people is very encouraging for those who are immunosuppressed. So we don't see any age-related effects or very much with the vaccines. So that's good news for those who are immunosuppressed.
So the myth that 80+ population feel that they are being used as guinea pig is completely wrong.
Yes, I mean, the trials included those over 65 years of age, obviously smaller numbers towards the top end of the age range, but all the data that we've collected, for example, from blood samples, shows that both the antibody and cell responses to these vaccines are remarkably good in older people. And that's in contrast to other vaccines where you don't get a good response or even any response at all in older people. So they are just remarkably good vaccines.
Thank you. Dr. Noham, I want to get Pfizer vaccine, but you're telling me I'll only have Oxford. How can you do that? It's my choice after all. I'm the patient, isn't it? Why can't you indulge in me, indulge in my choice?
Well, I mean, it's your choice to have the vaccine, but once you choose to have the vaccine, I'm afraid it's not your choice about which one it is. Both vaccines are absolutely safe. The MHRA is very clear about that. All the experts are very clear about that. And hopefully this evening and the conversations, they convey the fact that both vaccines are very safe. And so I hope anyone who chooses to have the vaccines would feel that they've already expressed their choice and wouldn't be asking for any particular one, because both vaccines are effective and safe.
Thank you. I think we're just about an hour allocated to us for this particular segment. I know the minister's got to leave. May I ask Minister to provide your closing comments before you go, and then we'll take on our question and answers from the audience.
Okay, well, thank you again for giving up the time. I have found it interesting. I'll be interested in the feedback and what we get after the event too, because as I said in answer to one of the questions, this isn't it in terms of we have engaged with these particular communities that are part of our national story and part of our future. So I look forward to hearing more about the rest of the event, more myth busting, and then seeing how we can usefully put out information and some of the questions people have asked today. Because the questions that get asked over not just the session we've had, but the next hour that I know you're going to have will be things that other people will be interested in too. So we have to find a way to make use of not just the 100+ people who are engaged in this tonight, but the many more who will have some of the same concerns and interests that we all have too. So thank you for your time. And I look forward to seeing you not just through the weeks and months ahead on a screen. I'm afraid if you live in Wales, you can't really escape me. If you turn the TV on, you may well find me smiling at you in a different suit and tie combination. But I look forward to seeing many of you in a better future in person when we get through the pandemic, as we will do eventually. And let's look forward to a better tomorrow for all of us. Many thanks for your time. I look forward to seeing you again, Keshav. Take care.
Thank you, Minister. Much appreciated.